I guess I'll kind of start by introducing myself. So my name is Scott Grankla. I'm a PA. I went to school at the University of Colorado. I graduated last May, so a little over a year ago, and then came out to Flagstaff to start working for Mountain Heart, and ended up kind of in electrophysiology, which is the cardiac rhythms specifically. And so I work with all the cardiologists at Mountain Heart, but primarily Dr. Cataldo. So I spend about 2/3 of my time here in the hospital. I'm here Monday through Friday mornings, and then I'm in the office 3 afternoons a week. And so kind of seeing patients in the hospital are either new consults, procedures that we're doing, and then also following up in the clinic. So I kind of do a little bit of everything, but I don't take call and I don't work weekends or nights, so pretty nice. The focus of this lecture is just kind of more on the medications that we use for the treatment of cardiac arrhythmias, and some of the specific considerations, kind of hoping from a nursing standpoint so you can understand why we use these medications, what some of the risks are, and things to kind of keep in mind. So to start off, electrophysiology is a specialty within cardiology, and so Dr. Cataldo, who is the supervising physician that I work with, is board certified in cardiology and then did a fellowship in electrophysiology. So electrophysiology is cardiology, but we focus more specifically on heart rhythm disturbances, so electrical issues in the heart. So not so much coronary artery anatomy, but again, heart rhythm disturbances. And the way that we treat these is a few different strategies. And so medications, as with most things, is usually kind of the initial treatment for that. So what's the condition and how can we safely treat it? And then in our case, using devices. And so devices include cardiac pacemakers, cardiac defibrillators. And those are pacemakers used to treat slow heartbeats. And then we consider defibrillators as a way to terminate tachyarrhythmias, so hemodynamically unstable ventricular tachycardias primarily. And then we also have kind of our whole subset of doing ablation procedures. And so an ablation procedure is where we get inside the heart with electrical tip catheters and target where these arrhythmias are coming from and use radio frequency energy to try and terminate these. But that's a whole different kind of world and maybe a different lecture. But those are kind of the primary modalities. And so most of what you'll be seeing kind of on the nursing units is the medications that we're using and how we monitor them. So kind of again, just a brief conduction system overview. Cardiac conduction is all based on ion flow, so electrolytes through specific channels that are open and close in kind of sequence, and that's what creates a cardiac action potential or cardiac stimulation. And these are able to start kind of focally, so in a single area, and then propagate throughout. And so the typical cardiac conduction that we look at starts in the sinus node, which is again why we call it sinus rhythm, and that delivers a kind of impulse through the atria. That impulse then travels to the AV node or the AV junction, where it's kind of slowed down and then transmitted through the bundle branches, and then stimulating the ventricles. Ideally, pretty rapid conduction after we passed the AV node. And so the first thing I'll talk about is kind of the bradyarrhythmias. This is where medications are pretty limited, but just to kind of cover the whole spectrum. So sinus node dysfunction is a common one that we see, and this is typical with the aging process. So as we get older, the sinus node's ability to spontaneously depolarize or create its own action potentials can decrease. Sometimes that's asymptomatic. People aren't aware that their heart rate's in the 40s, they feel fine, their energy's fine. But this becomes a problem when patients are having persistent fatigue or unable to get their heart rate elevated with exertion. And so this can be extremely bothersome. When we evaluate that from a patient, there's not a medication that we can give long term to help with that. And so that would be an indication for a permanent pacemaker. And that's again coming from the sinus node. Sometimes in our evaluation, the medication that we would give would be atropine. Atropine is a parasympathetic antagonist, so we kind of block that vagal tone that can be slowing down our heart rate, and see if that's the result of it or if this is a true electrical conduction disturbance. The next part of kind of bradycardic arrhythmias is disease that's not related to the sinus node frequency, but is more related to conduction through the bundle branches. So when we talk about the heart block, this is where we see our Winky-Bach or Mobet's and complete heart block. And again, these are things that can be an absolute indication for permanent pacing. And just to kind of break this up, just because this is something that took me a little bit of time, like, oh yeah, that actually makes sense. When we have first degree AV block and second degree type 1 AV block, these are the kinds that we don't rush to put a pacemaker in because they're generally not an issue. Because what's happening is you're getting conduction, it's hitting the AV junction, the AV node, and then it's slowed down, but by the time it makes it to the kind of His-Purkinje system, the ventricles activate. And so every so often you can have prolonging non-conductive beat, but it's never going to be a prolonged pause. This starts becoming a problem when we see patterns like a second degree type 2, which means that all these impulses are making it through the AV node at the same rate, but because there's non-conducted, it means that every so often we're getting non-conduction through the bundle branches, so we're having ventricular pauses, ventricular standstill. Complete heart block is where the atria and the ventricle are operating completely autonomously, and that results in really slow rates from the ventricles, and again is unstable, so that's an indication for a permanent pacemaker. In this case, you just want to make sure that there's not medications that could be worsening it, so beta blockers, calcium channel blockers, some antiarrhythmics before you rush to put a device in. So tachyarrhythmias, this is where things start getting a little more interesting, and again is more where we treat medically, because the only way to kind of terminate a tachyarrhythmia without medication is with defibrillation or cardioversion. So the mechanisms that can cause tachyarrhythmias are, they can either relate from a kind of the normal conduction system going too fast. And so this would be, sinus tachycardia that's happening at the wrong times. And this can happen from either physiologic stressors, someone's sick, someone's bleeding, we're going to have a tachycardic response. Or this can also happen just as a result of kind of poor conduction or a condition called inappropriate sinus tachycardia, which is where there's sinus tachycardia at inappropriate times, so not related to conduction disturbances. And that is something that we will treat and is most typically found in younger patients. We'll get to that a little later on. The stuff that starts becoming more problematic is where we have enhanced automaticity. So every cell inside of the heart has its ability to create an action potential if there's the right kind of ion flow through the channels. And so enhanced automaticity basically means that you have areas outside of the normal conduction system, so sinus, AV, His-Purkinje, that are creating their own electrical impulses. Sometimes these are isolated, which would be a premature ventricular contraction. We see a PVC, or we see a PAC, a premature atrial contraction. When they're isolated, they're not typically so much of a problem, and these can typically be controlled with medications to help suppress these. And again, most patients aren't symptomatic as a result. They start becoming more of an issue when they become sustained. So you have an area that's creating rapid signals that's overriding the normal conduction system. So somewhere in the atria is producing a rate of say 120, and the sinus node wants to go at 60. And so that 120 overrides, and you have rapid conduction making it through to the ventricles. And patients are often symptomatic as a result of that. So treatments for this, and we'll kind of get more specific into the medications, but that's where we talk, calcium channel blockers, beta blockers, and a lot of our antiarrhythmics can be effective in suppressing these extra beats. And so those ones are, again, typically, benign, especially if they're coming from the atria, the upper chambers of the heart, because the AV node is able to slow the conduction. When these become kind of the sustained arrhythmias, this is where we're talking about impulse conduction. So these abnormal impulses are able to find reentrant circuits. Essentially, they're able to get onto a racetrack and create a self-sustaining arrhythmia. That self-sustaining arrhythmia can cause the atria to go very fast, and the result can cause the ventricles to go very fast. And so this is where we're talking about things like atrial flutter, reentrant tachycardia, and in some cases ventricular tachycardia. So the treatment for these typically we'll talk about if it's AV nodal dependent. So if we have a reentrant tachycardia circuit in the upper chambers, the atria that's going very rapidly and intersects the AV node, well, the AV node's going to activate and cause the ventricles. And so it's something that if we can stop conduction at the AV node, we can basically break that circuit, because part of that circuit is dependent on getting near the node. And so that's where a medication like adenosine can be very effective. Adenosine causes that short pause at the AV node, breaks that circuit, and allows the normal conduction system to override. Another way to kind of prevent or to stop these circuits is by doing a cardioversion. And so by doing a cardioversion, what's happening is we're delivering an electrical impulse that causes all the cells in the heart to depolarize and reset. And as they reset, now the primary system can normally take over. That's the sinus AV, is Purkinje. So, and again, those are kind of our reentrant ones. So AVNRT, in the case of Wolff-Parkinson-White syndrome, where you have a pathway that goes actually through the ventricles and back through the node. So we typically will treat those with adenosine in the acute phase, but also medications that can help slow down conduction at the AV node can be effective. So metoprolol and diltiazem. We'll go track these medications a little more specifically as well. But typically, again, when we see these reentrant circuits, long-term management typically entails the ablation. So an ablation, we can get in there, figure out where that circuit is, and eliminate an arm of it. So we're interrupting the racetrack electrically, or making a permanent burn there so that that circuit can't find itself and cause these tachycardia. So the primary condition that we treat, and the one that everybody certainly sees the most because it's the most common heart rhythm disturbance worldwide, is atrial fibrillation. And atrial fibrillation is probably about 40% of what I do in practice, because again, it's so frequent, and the treatment for it is difficult. There's no cure for atrial fibrillation. Everything we do is part of a treatment strategy. So ablations, medications, all that is how can we try and decrease the burden, make our patient feel comfortable. And so atrial fibrillation by nature isn't just based on a reentrant circuit. It's the result of multiple areas of the heart, typically in the left atrium, that are able to generate their own electrical impulses, create these short circuits. But essentially what's happening is the atria have so much electrical activity happening that's eventually making it to the AV node. But because the AV node has the ability to slow conduction, not every impulse makes it through. So the atria could be conducting at an irregular rate of, say, 300 or 400 times a minute, but the AV node's really only going to allow that to hit about 200 at the most, depending on the patient. So when we talk about treating atrial fibrillation, there's a lot of things that we have to take into account. And this is especially where the medications start becoming more specific and getting this under control. So the first thing that I look at when I see a patient with atrial fibrillation is, how can I prevent something bad from happening in this patient? How can I prevent them from dying or having a stroke? And so this is where the topic of anticoagulation comes up. And many of our patients here in the hospital are on some form of anticoagulation for many indications, but AFib probably being up there with one of the more common. So the way we decide which patient gets anticoagulation in atrial fibrillation is based on kind of this CHADS-VASc scoring system. And there are some other ones out there, but this is the most commonly used in the United States and most kind of evidence-based. And so when I meet a patient, I'm kind of thinking through all these questions, as I'm interviewing them. But anytime the CHADS-VASc score is at 2 or greater, we recommend that they're on some form of anticoagulation greater than aspirin to help prevent them from having a stroke. Because in again, the issue with atrial fibrillation is the upper chambers are going so quickly that there's not a forceful contraction, and there's an outpouching on the left atrium in everybody called the left atrial appendage, and it serves no role in cardiac output. It's just one of these leftover structures that at some point in evolution probably had some purpose. But in our case, it's basically this different type of tissue that has an outpouching that has very poor blood flow in and out, especially in rapid tachycardia. And so as we're in this atrial fibrillation, a blood clot can form inside of that pouch. If they go back into normal rhythm or there's a forceful enough contraction, that blood clot can break loose. The issue now is that we're in the left side of the heart. And so the first place that blood goes after it leaves the left ventricle is into the aorta, and then can go up into the brain and cause a stroke. And so we believe about 1 in 4 to 1 in 5 strokes are related to underlying atrial fibrillation that patients may or may not be aware of. And so that's why, again, we have to decide, does this patient need anticoagulation? And so when we look at the CHA2DS2-VASc scoring system, essentially what that means is there's an absolute risk involved with being on anticoagulation. Say that risk is 3% per person per year that they're going to have some bad bleeding event, a hospitalization for a nosebleed that needs cauterization, an abdominal bleed, or a traumatic injury, a head injury that causes an intracranial hemorrhage. And then we have to look at, okay, well, what's that patient's risk of having a stroke if they're having atrial fibrillation that comes and goes? And if their score is greater than or equal to 2, we perceive that their risk of a stroke is greater than the risk of a bleeding event, in which case we say they need to be on some type of anticoagulation long term. This is independent of if we've done an ablation, if they're on antiarrhythmic therapy. Knowing that they have atrial fibrillation is the indication to put them on a blood thinner. And what I tell my patients is, even if they're not having symptoms, we know they're not having events per their recorder. I don't want to find out my patient had a recurrence of atrial fibrillation by seeing them in the hospital with a stroke, because we don't know if and when the atrial fibrillation will come back. And we believe it's only about 5 minutes of sustained atrial fibrillation in certain circumstances can form a thrombus that can lead to a stroke. Other considerations we make with atrial fibrillation is, well, is this patient having symptoms? So a patient who's having atrial fibrillation, many patients will have symptoms, but some have no idea. And it's, again, all just going to be based on the rate. So we know that when a patient has sustained tachycardia as a result of atrial fibrillation, it can worsen their heart failure because it's increased, the cardiac demand when the tachycardic rate is greater than bradycardia. And so that's, part of the consideration is we need to treat their symptoms, and we also want to prevent their heart failure from getting worse. And that's where we kind of talk rate control versus rhythm control. And then, kind of the cousin to atrial fibrillation is a rhythm called atrial flutter. Atrial flutter is different from atrial fibrillation in the sense that it's based on a kind of, again, one of these reentrant circuits, and most commonly in the right atrium, but can also be in the left atrium. So when we treat someone with atrial fibrillation, it's kind of the same initial overview. Okay, well, we need to anticoagulate them because the stroke risk is perceived to be the same in atrial flutter as it is in atrial fibrillation. So even though atrial flutter is more regular, it's still so rapid that blood's not getting in and out of that atrial appendage effectively. And so we can treat this the same way with medications, but typically if someone has atrial flutter that we perceive to be typical, coming from the top right chamber, ablation is usually early in our kind of phases of treatment versus medical therapy. So any questions about the kind of atrial fibrillation, atrial flutter? We see a lot of it, and we'll talk more specifically about the medications here in a minute. But so then the other type of rhythms that we worry about, kind of more serious, are ventricular tachycardias. The main issue with ventricular arrhythmias is that they don't rely on the AV node. The AV node has the ability to kind of slow the rate of conduction. And so the atria, again, can be going at 300 or 400 times a minute, but the ventricles won't typically respond that fast. The patient's not going to feel well if their ventricular rate is 180, but they're likely not going to die as a result. In ventricular tachycardia, ventricular fibrillation, we can see ventricular rates that are 250, 300, and at that time, the ventricles don't have enough time to fill, and that's where we run into life-threatening arrhythmias. So we take ventricular arrhythmias very seriously, and the kind of management for it, we see a little bit of a difference there. So the typical way we break up ventricular tachycardias is into kind of an ischemic or an idiopathic. Idiopathic kind of being the catch-all for everything that's not related to known structural heart disease. So when somebody has a large MI, what's happening is there's an area of tissue that's becoming infarcted. And when you have tissue infarction, you're having abnormal electrical conduction in and out of that area as well. That can create these macro reentrant circuits around that scar, or in the case of dilated cardiomyopathy, areas where the ventricle has stretched. And that can lead to these very rapid arrhythmias that can be life-threatening. So when we treat these, and again, we'll kind of go into the medication classes, there are certain medications that are more effective than others in treating the ventricular arrhythmias. But as soon as somebody, it has documented ventricular arrhythmias that's required them to be defibrillated, they're at such a high risk of developing further ones that's where we consider implanting a defibrillator. We also implant a defibrillator in a patient who is at high risk. So their LV function is less than 30 to 35%. Means that they're at significant risk for developing unsafe ventricular arrhythmias, and that's an indication to implant a defibrillator, even if we've never seen ventricular tachycardia in the patient. And then the other type that we look at is this idiopathic. So this is where patients are having frequent PVCs, episodes of non-sustained VT, but there's no structural heart disease. They have normal LV function. They've never had an MI. There's no areas of ischemia or infarction. And this is similar to these atrial tachycardias. It just means that there's an area inside of the heart that's creating its own electrical impulses, and it can be at a kind of infrequent and sometimes rapid rate. Typically, the idiopathic ones have much better prognosis because they're not going to become sustained. So these we kind of are able to look at certain EKG patterns to tell where they're coming from, decide medication therapy, and then consider ablation for them. So this slide, I don't want to get too much into the, the channels. We'll just talk about the medications individually. But when we break our medications into categories, it's all based on which channel they're working on. So the normal cardiac action potential is based on, as I said, current flow or ion flow in and out of these specialized channels. And the antiarrhythmics are broken up into categories based on their primary channel that they act on. So sometimes these medications work by slowing how quickly the cell's able to depolarize, or increasing the recovery time. Because when the cell's cardiac myocytes recovering, it's unable to deliver an additional action potential. So that's a way to prevent these kind of arrhythmias from sustaining. So kind of just going in order of our primary classes of medications. Class 1 medications, this is acting on the sodium channel. And the medications in this are ones that we don't use a whole lot anymore. These used to be kind of the standards of ACLS. But medications, lidocaine was, before we had amiodarone, was one of these primary ACLS drugs for ventricular arrhythmias. In some cases, we still use it for ventricular arrhythmias. But I think since I've been here, maybe only 1 or 2 patients we've given IV lidocaine to. So this, is effective in suppressing ventricular arrhythmias that are related to areas of ischemia or infarction. They're not going to be very effective in idiopathic ventricular tachycardia. So there has to be something kind of wrong with the heart to begin with for lidocaine really to be effective for this. And with lidocaine, we see a lot of these neurologics, so dizziness, headaches. Patients typically don't feel very well when they're on IV lidocaine. Medications developed to have the same effect on channels, but it's an oral formulation of mixilotine. And mixilotine we kind of reserve for patients who have recurrent ventricular tachycardia and aren't responsive to any other agents. So I'd say I have a few patients who are on mixilotine, but again, that medication is typically not tolerated very well because of a lot of the neurologic side effects. And it has to be taken 3 times a day, every day. So the next kind of, as we go into these still sodium channels, is flecainide. And so flecainide is probably the most common antiarrhythmic that I prescribe, and one that we're going to probably see in a lot of patients as you're doing their med history. So flecainide is effective for a lot of different arrhythmias, especially for paroxysmal atrial fibrillation. And it works to kind of prevent recurrences, and it can actually be used to terminate atrial fibrillation when an event occurs. So this medication is typically very well tolerated. There's not a lot of side effects. Sometimes at higher doses, patients will have some kind of dizziness and visual disturbances. And some patients will have some chest pain, but the chest pain's not coronary in nature. It's kind of an atypical side effect, but typically at higher doses, we'll have patients who will say, I kind of get some chest discomfort with this medicine. In some cases, it can actually be proarrhythmic, and so it can, if given to the wrong patient, essentially it can lead to unsafe arrhythmias, but we screen all of our patients to make sure we're not giving it to those patients. So before we treat a patient with flecainide, we need to make sure that they don't have any evidence of ischemia or reduced LV function. There was a big medication trial, I'm not sure how many years ago exactly, where they are trying to suppress atrial fibrillation, and they found that patients who had coronary disease or heart failure who were given flecainide had a higher mortality. And so we have to screen all of our patients to make sure that this is a safe medication for them. And that's usually in the form of a stress echocardiogram, because that gives us an evaluation of their LV function. We can also evaluate for ischemia or wall motion abnormalities. And so in some cases, we use this for paroxysmal atrial fibrillation, or sometimes in the patient that has episodes that are so infrequent and typically associated with triggers that they can just carry the medication with them. So they have an episode, they can take a single dose of it, and that's sometimes effective in termination. At times we'll do that in the emergency department as well. So another medication very similar to flecainide is called propafenone. Propafenone has effects on the same channels and can be used. The same considerations have to be made. And so we have to make sure, again, they don't have any structural heart disease. So normal LV function, no evidence of ischemia before we can give this medication. It's typically not tolerated as well as flecainide. There's more kind of GI side effects, headaches, and so only if patients don't tolerate flecainide is the only time I'm prescribing propafenone. But we, again, always want to make sure that this patient doesn't have any evidence of ischemia or infarction. At times, we'll have patients who are seen by other providers. They started this medication. We discover down the road that they have evidence of an abnormal stress test, and we'll discontinue it because, again, it's not safe for long-term use in those patients. So then, kind of the next big category and most common medications that we're going to see, because they have so many indications, are beta blockers. And so beta blockers work to antagonize the effects of beta 1 and beta 2, and kind of beta 3, but we won't get into those receptors throughout the body. Beta 1 receptors we can kind of say are more cardiac related. Beta 2, these are a little bit more widely distributed bronchial. So that's why a beta agonist used for asthma is treating the vasoconstriction in the airways. So a beta blocker will worsen that, essentially. So they have an opposite of that. And so when we look at our beta blockers, there's different categories of them. The first generation are non-selective, which means that they act on both beta 1 and beta 2, so cardiac and extracardiac receptors. And these are ones like propranolol, nadolol, timolol. We don't see these used in clinical practice really much anymore, because you're usually treating one thing or the other. You don't want kind of the non-selective beta antagonism. The second generations are the ones that we see probably about the most frequently. So these ones are selective, are more cardiac specific. And so metoprolol has an effect on working directly on the cardiac myocytes to slow down the rate of conduction in the AV node, and then also conduction through, or rate of conduction through the sinus node, and then slow down the rate of conduction through the AV node. So these are kind of our nodal blocking agents. Bispirolol, atenolol, esmolol, those are all kind of in the same category. And we'll get into a little more details about them specifically in a second. But the third generations, these are the ones that they're considered to be non-selective, but there's different affinities. So they are typically more beta-1, but they have components of beta-2, but they also have extra effects. And so they can act on alpha receptors and other receptors that are biased. We get these kind of specific profile of them. And these ones are carvedilol, which again we see used very frequently, and then sotalol, which I'll get into, especially as its antiarrhythmic effects. So the use of these medications is typically not as a first line, but they can be used for management of hypertension. But we most often see them as used in heart failure, because in heart failure we want to slow down oxygen demand in the myocardium. So we can do that either by slowing down the rate or the force of contraction, and that's what beta blockers are able to do. So in EP, we use these more based on the nodal blocking effect. So by slowing down the excitability through either the sinus node, AV node, or all the cardiac myocytes. So beta blockers are effective in suppressing atrial arrhythmia, or slowing down atrial arrhythmias and suppressing ventricular arrhythmias. Carvedilol, bispropolol, and metoprolol succinate, you'll often see in our notes, we'll say evidence-based beta blocker. So these are the ones that the American Heart Association has decided, studying all of these patients, which ones reduce mortality, morbidity in patients with heart failure. So the other kind of non-selective beta blockers don't have that effect. And so in our case, metoprolol succinate we use the most frequently from an EP standpoint because it has the best effect in restricting arrhythmias, but also in evidence-based for preventing worsening outcomes with heart failure. So considerations with when we take into account when we're choosing a beta blocker for a patient is knowing that young patients typically don't tolerate these medications very well because they result in the hypotension, the bradycardia, and there are some central nervous system effects too that are able to just make it so patients feel very tired on them. I mean, even our older patients as well. And so some patients are just fine on them, but that's the most common side effect we see is fatigue. And the effect on blood pressure lowering is based on the agent. So carvedilol is more effective in reducing blood pressure than metoprolol, but again, differing degree, and it's going to be patient dependent. The non-selective agents, because we have a beta antagonist, and we're giving, for asthma we treat with a beta agonist, it's going to worsen bronchial constriction related to asthma, and so we avoid the non-selective agents in patients who have bad COPD or bad asthma. And because they have a role at slowing conduction through the AV node, they can cause worsen AV node dysfunction, so AV blocks or dysprotension disease. So that kind of as we move through our antiarrhythmics, amiodarone is a medication that we all again hear about in our ACLS course, and is a primarily a class 3 agent. So it acts on potassium channels, but we consider this more of a dirty drug in the sense it has effects on multiple receptors and other parts of the body, extracardiac. And because of that, we really limit its use for long-term therapy. Again, it's very, very effective, likely because it acts on many receptors throughout. We don't understand exactly the pharmacologic profile of it, but it's the toxic effects, and we'll kind of go through what some of those are, really limited to use, and especially from an EP specific standpoint. With this medicine, one of the main issues is it has kind of iodine in it, and so part of that makes it so it builds up in the system, and it can affect many other organ systems, but it takes a very long time for it to get to steady state. So, which is why when you're giving ACLS, you're giving boluses, infusion, that type. And when we prescribe it, it's they're taking a loading dose, and so they're taking it 3 times a day for 3 weeks, and they're taking it daily because it takes so long to get into the system. But because of that, it takes just as long or longer to get out of the system, which makes treatment very difficult. Benefit of this medication is it can be used in patients with structural heart disease, and so we don't have to screen our patients. We can start them on it, but again, we have to be careful who we started on and avoiding long-term use in it. So when we talk about some of these side effects, the most common that we see are going to be thyroid dysfunction. It can cause hypo and hyperthyroidism. Part of that's related to the iodine radical, but it's also blocks conversion of our thyroid precursors, T4 to the active T3. And it can worsen pulmonary disease, pulmonary fibrosis. Patients who've been on it for a long term kind of have the amiodarone blue skin, and so actually see changes in their skin hue. We get, there's can be hepatic dysfunction. I mean, it's a nasty agent for long-term use. But again, it's the most effective medicine that we have for controlling ventricular and atrial arrhythmias. But we really have to select which patients we're going to give it to. So again, we reserve it for temporary management or for particularly malignant arrhythmias that aren't controlled with anything else. So sometimes we'll prescribe it as a short course. And so patients following cardiovascular surgery, CABG, valve replacement, they can develop irritability, atrial fibrillation in the postoperative course. And we could typically have them on a short course of amiodarone, expected to be 3-4 weeks, while we then wean them off of it, and then those typically resolve. Yeah.
What's Cataldo's preference on amiodarone tapering?
So when we do, we load as doing the 200 milligrams 3 times a day and then once a day. We don't do too much in terms of tapering. Usually we're going to all or nothing discontinue. Okay. So we typically won't go back down. There are some providers, will say, well, let's do 100 milligrams. In the rare cases that we have patients who necessitate long-term therapy, we'll try lower doses and see if that's effective again, because a lot of this toxicity is just the more doses you get over the more time, the more problems we're going to run into. The patients that are on long-term therapy with it, we do serial monitoring, so pulmonary function testing to evaluate if the pulmonary fibrosis could be getting worse. We do thyroid testing, we do hepatic function testing, and this is, again, just part of the monitoring protocol with it. If we note that there are issues, then we're discontinuing it and we're trying to figure out what's the most appropriate medication after that. Sometimes amiodarone can cause hypotension, but typically that's pretty minimal. We don't usually see a marked drop in their pressures. And so typically a low pressure doesn't preclude us from giving amiodarone, especially if there's something else that we're trying to manage. Amiodarone also interacts with numerous medications, namely warfarin. So you had, back in the day before we had these newer agents, you had patients who were on amiodarone and warfarin that caused their INR to be all over the place. And we still have patients like that, and it's a constant nightmare. And so again, amiodarone effective, but we really try everything we can to not use it for long term. So after amiodarone is found to have all these side effects, the pharmaceutical companies say, well, how can we have all the effects of amiodarone but not have the long-term toxicity? And so this is where they developed a medication called Voltac or dronedarone. And this medicine is amiodarone without the iodine, but it's not as efficacious as amiodarone. So it doesn't have quite the same benefits in suppressing ventricular or atrial arrhythmias. And it has been shown to be not favorable. It increases mortality, morbidity in patients who have heart failure with reduced ejection fraction. So we avoid this medication in patients who have reduced LV function. But the benefit of it is that we can use it in patients regardless of any history of coronary disease or ischemia. So if we have a patient who all we know about them is what their LV function is, they haven't had a stress test, they haven't had a heart cath, we can safely start them on Multac, and typically for the short term, because a lot of patients don't tolerate this medication well due to GI side effects, which are the case in probably about 1 in 5 or 1 in 4 patients, and it's not really all that effective in suppression of especially atrial fibrillation. It can also be pretty expensive too, because there's no generic form of it, and so that's always a consideration that we have to take into account. But the most common use for this medication for us is we meet a patient in the hospital, new onset atrial fibrillation, they're in the hospital for something else. Now is not a good time to do an ischemic evaluation. We want to get them into normal rhythm. We cardiovert them, we put them on a short course of Multac, and as an outpatient, they get a stress test, and then we can decide if we can treat them with flecainide or use a different agent. So this is typically a temporary medication against this, not usually tolerated that well, and really isn't all that effective. So again, we can give it before knowing their ischemic evaluation, and once we know that they have appropriate LV function and renal dysfunction as well. So some of these other medicines, if they have really bad renal dysfunction, we can't give them. So this medicine is cleared in the liver, and so it's an easy one to just go with, but it's, again, not great for long-term therapy. So then the next medicine, and especially those of you that work in 3 South or step down, see this one quite a bit, is sotalol. And this is probably the most common, well, the most common that we're prescribing for long-term use in patients with some form of structural heart disease. So either heart failure or evidence of prior ischemia. So this is a non-selective beta blocker, and it also works on blocking potassium channels. So we get the antiarrhythmic benefit from the potassium channels, and the beta blocker component is kind of just with the drug. It's something that is, when this medication was developed, that was what's there, and it's kind of something that we deal with. It can be helpful in patients with low degree of heart failure, kind of a borderline LV function. Having that beta blocker component can be useful, but because it's non-selective, it can worsen COPD or asthma. And so, as much as we like this medicine, we can't give it in patients who have COPD, asthma, because it's going to make those worse. And this can be effective in both ventricular and atrial arrhythmias. The most common use you'll see it for is treating paroxysmal atrial fibrillation. And we can again use it in coronary disease, and unless there's severe LV dysfunction, it's safe to use. So because this acts on the potassium channels slow repolarization, we're going to prolong our QT interval. And so significant prolongation of the QT interval can lead to the rhythm torsade de poids, which is life-threatening ventricular tachycardia that can lead to ventricular fibrillation. And so because of that, we give this medication in the hospital. And this is, again, where you guys are going to see it as we're monitoring. So before we decide what patient's we have to look at our patient and decide which antiarrhythmic is the best for them. So if they're getting sotalol, it means that they weren't a candidate for these medications that we give as outpatient. So flecainide, propafenone, Multac, and they're not responding to rate control. So when we start this medication, there's certain parameters that we take into account. So we need to make sure that their potassium and their magnesium are greater than 4 and 2 respectively. And that's, again, because these low potassium and low magnesium can cause prolongation of the QT interval. So we need to make sure that they're at the right levels there and then replace if needed. We also look at what their baseline QT interval is, so we know as we're dosing how much it's prolonging. And then we also take a look at what their renal function is, because this is a renally cleared medicine, and there are dosing considerations that we'll take into account based on their creatinine clearance. So with the monitoring for this, we need to keep them in the hospital for a total of 6 doses. 6 doses being the point where this medication is felt to be at steady state. And so, even if they take a first dose of 120 milligrams, they're not going to have the effect of 120 milligrams of circulating drug until it reaches those multiple half-lives and lives and reach steady state. And so by the 6th dose is where it's felt to be, that's going to be their maximum QT prolongation. If they're going to develop significant QT prolongation or develop torsades, it's going to be in that initial loading phase. And so that's why we keep patients in the hospital for the 6 doses. Our protocol here is to keep patients in 3 south or higher, so 3 south, step down, CCU, all that, because we want them continuously on tele, and part of it too is being with the nursing staff that's the most used to using these medications, because they are there's a lot of questions that come up about them as well. And so we keep them in 3 south, and with this medicine, the risk of torsades is pretty low, and it doesn't have typically significant QT prolongation. And so in our case, we do EKGs every morning. And so we do an EKG at 7 o'clock every morning to watch what the QT interval is doing. And we base this off of what their baseline is, not what the number on the paper shows up as, because that can be often very inaccurate. And then we maintain that their electrolytes stay therapeutic throughout, and then at the end of their hospitalization, we'll decide if they need to go home on, if they require 20 milliequivalents of potassium every day, we'll then send them home on that. We also discontinue any medications that could prolong the QT interval. So some of the main side effects that we'll see with this is because it's a beta blocker, non-selectives, you can have patients increase wheezing, especially with COPD or asthma, or these patients who are kind of borderline, they're not on any therapy, but they do have some degree of it. It can worsen it, and that might not be the right patient for it. We'll also see some bradycardia. So as the doses go up, we'll see bradycardia, not uncommon for patients to be in the 50s, high 40s, and we decide to continue it based on their symptoms. If we start seeing evidence of AV node dysfunction, so AV block, we'll stop the medication because it's the beta blocker component is something that's unsafe in that given patient. But again, overall, this medication is, once we've done the loading, it's very effective in preventing recurrences of atrial fibrillation or suppressing forms of ventricular tachycardia. But we, because there's a risk of life-threatening arrhythmias, we really need to make sure that these are the right patients. Because we will have patients where we start them on a dose, we lower it to a point where it's no longer effective, and we have to choose a different medication. With the sotalol, however, just based on kind of the nature of it, if the patient's been on it in the past, just they're on 120 milligrams twice a day, we did an ablation on them, now they're having recurrences, we can restart it without putting them in the hospital again, because we know that they tolerated a certain dose, as long as we just take a look at their baseline electrolytes and baseline QT, if there haven't been any significant changes. So the next medication, same class, is essentially sotalol without the beta blocker. This is dofetilide, Ticacin. This is a medication that we have started to use here, is used nationwide in large facilities as, again, a very effective medication, but it does have a risk of developing the QT prolongation and torsades, and that risk is greater than sotalol. But the benefits of this medication is that it's able to effectively suppress atrial fibrillation in many cases, ventricular arrhythmias, and it doesn't have adverse side effects that patients appreciate. There's no GI side effects, there's no toxicity related to it. It doesn't result in bradycardia, bronchodilation, anything like that. So it's a very effective medication, but we really have to screen our patients to decide who's the most appropriate for it. Because this medication can prolong the QT interval and has a higher incidence of torsades, we monitor it the same way, the 6 doses for it to reach steady state, but we have a different monitoring protocol for it. And so our protocol for this medication is, first we need to confirm that there's really no other better option for them, because we don't want to give a medication if the risks outweigh the benefits, or there's another agent that could be just as effective. And so before we start this medication, again, we take a baseline EKG, make sure the QT interval is not prolonged, But instead of doing daily EKGs with this medicine, we do an EKG 2 hours after each dose. The idea being is that after they take that oral dose, 2 hours is where they found it hit kind of that peak level. So where the longest QT prolongation is going to be is 2 hours after each dose. And so it's pretty important that this medication gets given at the right time. So at 9 o'clock at night, 9 o'clock in the morning, and there's an EKG done pretty close to 2 hours after. So 11 at night or 11 in the morning. And if it's it doesn't seem like it's ordered, there's not a teletech, it's always going to be called because sometimes these recurring orders get lost in tele, and we'll get these a little bit later. We won't get them at all. So again, same idea. We monitor their electrolytes, keeping the magnesium greater than 2 and potassium greater than 4. And with this medication, again, because there's a higher incidence of torsades in those first 6 doses, we keep our patients in step down or higher for the whole loading process. Any form of wide complex tachycardia for tele, say, what's going on there? That looks a little, where's the artifact? And if you have any reason to believe it's not an artifact, you just need to call a code because this can become a life-threatening arrhythmia. The treatment for torsades as part of a code, mainstay of it is giving magnesium. Magnesium can help bring that QT interval in and help terminate this. And it's not a slow infusion. This is fast push, a 1 gram, 2 gram magnesium because we're treating a life-threatening arrhythmia. Other considerations with this medication is it has gone generic, but it can still be pretty expensive, and the pharmacies don't stock it because we're the only people in Northern Arizona that are prescribing this. And so, early in the admission, when I know they're going to be on it, I'll send it to their pharmacy. The pharmacies, it seems like they're still not always ordering it, and so I'm trying to really figure it out with these pharmacies in terms of, yes, they need this medicine, because typically they come in on a Monday or a Tuesday, they're discharged on a Friday, and then we say, well, how are they going to get it now? And we've had some issues with that. So we're working on trying to get this to make sure it's available for the patient at the time of discharge. And a lot of the nursing staff have been really helpful in calling all the pharmacies in Arizona, trying to track it down for our patients. And I'm trying to figure out the best way to make this happen. So, when we talk about the QT interval, this is, part of the EKG that's very important, especially from a EP standpoint with these medications. And, again, this represents kind of that recovery phase of ventricular depolarization. Well, it covers the whole span from depolarization to contraction to recovery. And with the QT interval, our EKG monitors, and really any EKG monitor they're not very good at reading intervals. They're machines, they're imperfect systems, they're looking for what it thinks is a T wave. And a lot of how we read EKGs is pattern recognition. We can tell what's artifact, we can tell what's not, just looking at enough of them. And so I don't even look at the numbers that the EKGs give. I do a manual interpretation because, again, these numbers are going to be all over the place, and they can, we do believe it's either falsely prolonged or falsely short, especially now that we have to open EKG. You click on EKG and it shows you the numbers, but I wouldn't trust that, especially when we know there's going to be a lot of artifact on these. With the QT interval, with a patient who has a wide QRS, so they have a right bundle branch block, left bundle branch block, or a wide pace duration, we can see a long QT interval because it's taking into account the depolarization, which is prolonged, but we're not looking for what that number is, we're looking for what is prolonged past their baseline. And so when we check these, that's what we're taking into account, deciding dosing.
That's mostly for ventricularly paced. That's not A-paced, right?
Right, yeah, all ventricular paced, yeah. And because the QT interval is going to change with rate, we have to correct it. So there's the QT, which is the absolute time between the Q wave and the end of the T wave, but that's going to that's a number. So say it's 400, but if they're going at 100 beats a minute, that's going to be prolonged. And so there's a formula that we take into account called the Bazit's formula, is the one that we use here, and it's I always just type it in basically because it's rate dependent. So as the rate goes up, even if we have our absolute QT interval is, say, 400. As the rate gets higher, that number is going to get higher, 450, 460, 470, because we need to be able to compare what the corrected QT is based on their rate. So, again, the measurement of it, we need to do this on a 12-lead EKG so that we can compare it to multiple leads. And so when we get these EKGs for monitoring medications, we need to make sure that they have very clear, legible T waves in multiple leads. And if we're not seeing that, and we say, I can't tell what a T wave is, we need to repeat the EKG because we really need to know where the end of that T wave is to decide on safe dosing. And yeah. So as we kind of take this all back together into how we treat atrial fibrillation, there's again a lot of these factors that I take into account when I meet a patient. I look at their history and decide which antiarrhythmic is safe for them. And so for the maintenance of silence rhythm, we could say that there's no structural heart disease. We don't have a normal echo, normal stress test. We can start them on an easy agent, flecainide, propranolone, dronedarone, Voltac in some cases. But we can do this as an outpatient and see how they do. Typically, if a patient is otherwise healthy, they fail one of those initial medications, then we'll go to ablation. And ablation is a whole kind of different topic, but the take-home of ablation is it's not a cure. It's part of the treatment strategy, especially for atrial fibrillation. So we'll have patients who are on a medicine, say they're on flecainide, they're still having episodes. We do an ablation. They might be symptom-free for many years. If they have recurrences, it's usually easier to treat with medication. And so if they have recurrences, it doesn't mean the ablation failed. It means that, well, we probably have better luck treating with medications in the future. So again, this is just kind of a overview of the AHI guidelines, and this is what we base our practice off of. That pretty much any EP does for choosing which medication to use. And I talked about some of these specifics with each of the patients or each of the medications. So the next class of medications is our calcium channel blockers. These are the class 4 agents, and we typically break these up into two broad categories. So we have our dihydropyridines and non-dihydropyridine. So dihydropyridine are our medications that are typically used for hypertension, and these have more of a specific effect on reducing arterial tone and don't have very much of an effect on cardiac or slowing rate down. So this is amlodipine, nifedipine, nicardipine. So some of these are used in the acute setting. Some of them are used for more long-term management. The non-dihydropyridines, these are verapamil and diltiazem. Diltiazem we see all the time for used in rate control for rapid atrial fibrillation, atrial flutter, and because it has a role on the SA node and specifically, especially the AV node. And so this can be IV or oral dosing. It can also be used for kind of helping slowing down of that reentrance circuit. I think we'll talk about. Yeah, so diltiazem and verapamil. So diltiazem, again, if someone comes in rapid atrial fibrillation, that's usually one of the first strategies is let's see how they do on diltiazem, because diltiazem doesn't do sort of great role in providing hypotension. So patients can usually tolerate pretty high doses. And it can also be used in treating these AV node dependent tachycardias. So as I was saying with the adenosine, you can stop the conduction at the AV node and eliminate these tachycardias. Diltiazem has a similar role, not nearly as effective, however. We can often use these with beta blockers. Kind of on you'll get a drug pop-up that says watch out. You can worsen AV node conduction disturbances if they're on a calcium channel blocker and a beta blocker like metoprolol, but we have to make sure our patients don't have underlying AV node hypertension disease before we treat them with both. Verapamil specifically can be effective in suppressing certain types of idiopathic ventricular tachycardia. So people that again have PVCs, non-sustained VT, but no structural heart disease. The Bell-Hostel type, that's if you see verapamil for it, it's a certain type of idiopathic that we're trying to treat. So Adenosine, this medicine is used, it doesn't have any long-term maintenance therapy. It's used basically as kind of our ACLS drug for termination or diagnosis of narrow complex tachycardias. So this medication has a very short half-life, to the order of seconds. And so the patient comes in, they have a rapid narrow complex tachycardia. You don't see any regular P waves. You think, well, this could be some form of reentrant tachycardia, or it could be an atrial flutter. And so what we do is we give this medication. Patients obviously typically don't feel very well when you give it. They say, they feel the impending doom, and then you'll typically see a complete AV block, and the ventricles come back. And usually that can terminate these AV nodal reentrant type of tachycardias. Sometimes we'll give it to help us diagnose what's going on too. If we think a patient's having atrial flutter with rapid conduction, you can't usually tell by just looking at EKG if it's AV nodal reentrant tachycardia or if it's coming from the atria. And so by giving adenosine in these cases, we'll typically run a 12-lead EKG continuous, because if we block the AV node, we don't see the QRS segments, which are confusing what we're interpreting. We see the flutter waves, and we say, oh, okay, it's atrial flutter, and then they go back into the rapid tachycardia. But that's enough for us to know, okay, is this atrial flutter, or is this a reentrant tachycardia? So that's the cases that will, and I know we've done it a couple times bedside for helping us make diagnosis, and in some cases terminating the arrhythmia. There are some atrial tachycardias coming from a single spot in the atrium, very rapid, that will respond to these as well, that are not part of our reentrant circuit. That's just kind of a little side note. Another medication that we still see and we still prescribe in some rare cases is digoxin. So digoxin works by blocking the sodium-potassium ATPase in the myocardium. What that does is it helps, it increases calcium, which can help with ionotropy, so increasing the force of contraction. This medication used to be used all the time for any patient with heart failure, because their heart failure, they're having poor contraction. Let's help them feel better. And it can provide some degree of symptom relief, but it has a very narrow therapeutic range. And so it can easily be underdosed, but more often be overdosed, especially if they have any form of renal dysfunction. So this digoxin can build up and result in some of these toxic side effects. So we typically will reserve this medicine if a patient is having very difficult to control atrial fibrillation. We have cardioverted, they keep going back in. We need something for rate control while we can prepare to do an ablation. And their blood pressures aren't tolerating the doses of metoprolol or diltiazem. And again, because it has the ability to increase the force of contraction, you can provide rate control without providing hypotension. So again, this will usually be used with other AV nodal blocking agents to help prevent that rapid ventricular response. The rate control with this medicine, though, is most prevalent at rest. You'll see, oh, wow, my patient's, in the 70s at rest on the dish, but as soon as they get up, now they're 130, because it doesn't do a great role once they're actually up and moving around. So that's just one consideration to make, is it can be very good at rest, but not so great with exertion. So this toxic effects, this is where we see ditch toxicity, PTs, can be proarrhythmic, can cause AV block. So again, we typically don't use this because we found that for chronic therapy it can actually increase bad outcomes. So the next medication, I've probably only had a couple patients here in the hospital who've been on this before, and we've had to get, it might be on formulary now, but it's a new medication called evadribine or Corlinor, which actually works specifically on the sinus node. And so what it's able to do is prevent the kind of passive depolarization and the passive contraction that initiates the sinus node by interrupting what's known as the funny current. I don't know how they picked that, but it's the IF, and it's just kind of this slow depolarization that causes the sinus node. So this medication can be very effective in patients who have arrhythmias that are, coming from the sinus node, or just basically malignant sinus tachycardia. So sinus tachycardia, that's making them either feel poorly, so in case of inappropriate sinus tachycardia, which is most common in young, healthy women, or in the case of a patient with heart failure where they're having this rapid tachycardia, which is actually worsening. It's approved for use with heart failure, and so again, we have these patients who have terrible LV function, 10-15%, and they're tachycardic in 130s. We can't give them beta blockers because the pressures won't tolerate it. This is a medication to use for that. As an outpatient, I have many patients I try to get this approved for treatment of inappropriate sinus tachycardia. So these young, healthy patients with the insurance companies don't like to prescribe it, even though it's very well tolerated, because it doesn't have all the extra effects that we see with beta blockers. So any questions about the antiarrhythmics? All right. The last thing I'll go through is just our anticoagulants. Anticoagulants relate to electrophysiology based on atrial fibrillation. So again, any patient with atrial fibrillation, that we have to risk stratify them and decide if they need to be on an anticoagulant or if an aspirin is appropriate. If you look at the CHADS-VASc scoring system, most patients end up requiring full anticoagulation because a lot of atrial fibrillation happens in older people. Just being female and 65, your score is a 2, and you have to be on a blood thinner. So the main the first medication that was used for this, and the one that we still will see, is warfarin. Warfarin works by blocking vitamin K, and vitamin K is part of this whole coagulation cascade. All of our many of these factors require vitamin K to be effective, and so by blocking the synthesis of these clotting factors or components of the clotting cascade, we can thin the blood. With atrial fibrillation, the INR needs to be between 2 and 3, but that's different depending on what the indication is. The problem with INR, even though we can see where a patient is as many cared for patients with warfarin, is that number can be all over the place. They can come in and be 1.5, or they can come in and be 4, 5, 6, and have these serious bleeding events because it interacts with so many medications, foods, that patients can be up and down, come on this roller coaster, which makes things unsafe because they're often subtherapeutic, so now they're at risk of developing the thrombus, or they're supratherapeutic, now they're at risk of having a spontaneous hemorrhage. Benefit of this medicine is it can be reversed relatively easily, you just flood them with vitamin K, and now the stuff that's blocked, you can just overload it. And so it's nice because we can reverse it relatively easily, and we can know how far we've reversed it by checking the INR. This medication still has indications if a patient has valvular atrial fibrillation, so if they have atrial fibrillation associated with valve replacement. So even if it's a bioprosthetic valve or any other valvular abnormalities, the other agents haven't been proven to be safe, and so this is still recommended in those patients. Also recommended in any patients with mechanical valves. So that's kind of the caveat when patients decide if they want a bioprosthetic or a mechanical valve. So the mechanical valve lasts forever, but you have to be on warfarin forever. So this medication does definitely result in a lot of headaches, especially from our end. We very rarely start patients on it these days. So the medication that we use the most frequently for atrial fibrillation is Eliquis, which is also known as apixaban. And so this medication doesn't work by blocking multiple components. It blocks a single important component in the clotting cascade, and that's factor 10A. And that's why it's called apixaban, is that XA is 10A, rivaroxaban, Xarelto is 10A as well. So this medication, there's no way we can measure the effect of it. We don't know how therapeutic it is, but we base the dosing off of their renal function. And so by having a patient take 5 milligrams twice a day, we can say that they're have significant reduction in the risk of developing a thrombus related to atrial fibrillation. Again, there's no reversal agent, but this is the only medication that's proven to be superior, better than warfarin for preventing strokes in patients with AFib. And this is kind of all goes back to the this Aristotle trial, which really opened up the kind of, okay, well, we really need to start using these medicines because this actually has been proven to be safer in my patients than warfarin, even though it's more expensive. But most insurance companies are finding, well, we can get this for IHS patients. When a patient qualifies, we'll get them onto this. There is a lower dose of 2.5 milligrams twice a day, but we really should only be giving that to patients who meet two of these risk factors, two of these components. So either they're greater than 80, they're less than 60 kilos, or their creatinine is greater than 1.5. It's proven, sometimes we'll say, oh, I don't want my patient to bleed, I'm going to give them the low dose, but the low dose is just not shown to be protective unless these factors exist. So we really avoid giving the low dose if we can, because again, we're trying to protect our patients. The other medication, same, almost identical to Eliquis, is rivaroxaban or Xarelto. Acts in the same way, but it has a once daily dosing. The only difference with this medicine is in this Aristotle trial, they showed that it was not superior to warfarin. And so it's basically this trial showed that Eliquis is better. There are still patients who I'll give Xarelto to. I think the benefits are pretty, I think they're pretty close to each other, but again, all things equal, I pick Eliquis. Again, there's no reversal agent for it. And the renal dosing is 15 milligrams. So you're cutting the dose and taking a quarter off of it instead of a half. And again, this has indications for many other DVT prevention, and those are all going to be kind of specific dosing strategies. Other medication, dabigatran, this was the first, this came out before Eliquis, before Xarelto. This acts in a different way, inhibiting thrombin, but we don't use this medication very often because patients typically don't tolerate it very well. And again, it's shown to be not superior to warfarin, so it's no better than using Eliquis or Xarelto. And although it does have a reversal agent, which I believe we actually have here, it's extremely, extremely expensive. And especially with Eliquis, Xarelto, those medications are able to clear relatively quickly. And so if something needs to be done, we can usually work around that. And there are some indications that this is used more. I know the VA really likes dabigatran, and so some of our patients have to be on that because that's all the VA will pay for them, unless we can really prove that they need to be on something else. And we can measure the effect of it with a specialized test. I looked it up. I don't think we can do the ECT test here, but it's basically just to tell you, well, it doesn't really give us that much information. So dabigatran, again, an anticoagulant, it can be used for atrial fibrillation, but typically not one of our go-tos because it's not tolerated very well, and it isn't shown to be better than the other agents. So I'll just quickly go through some kind of cases just to show what goes into my mind when I'm just selecting medication for a patient, and then we can. Actually, any questions before I go into some cases? Yeah.
I have a question. When you have a ventricularly paced patient, what do you generally do for a correction factor? Do you just use the standard, like the old 50 millisecond correction factor? Like, how do you do that when you're looking at those type of patients?
Yeah, so I'm looking at what their baseline is, and so I'm looking at making my measurement with their YQRS and saying, okay, I'm considering their baseline QTC to be approximately. And it's sometimes easy too because we compare these apples to apples. We'll be pacing at 60 and we'll be pacing at 60 the next day. But I'll take a look and see what it is at that time, and then just see what the prolongation is beyond that. Because there's not really a well-studied correction factor that we can use for it because everybody's QRS duration is going to be different. There's formulas that have tried to quantify that, but typically we just take a look at that.
Yeah. So like the reason I'm asking is like when I'm looking at medications, if I have like 2 or 3 QT prolongating medications, I'm pulling a strip on that, and I'm getting a QT of 500 or 520. You know what I mean? And that's not really clinically appropriate for me to act upon when I be faced like that. So how do you know what I mean? Like what's the best way for me to just kind of like estimate what it actually is? You know what I mean?
Yeah. I don't have a great answer for that because it's hard to make a diagnosis of long QT syndrome when someone has a very wide QRS duration. So the one way is discontinue the agents and see what it does. But it's if they've been on them chronically and they haven't had any issues. I'm also less nervous when a patient has a defibrillator that's pacing them, and I know if they have a defibrillator that can sense ventricular arrhythmia and terminate it if necessary. So, but yeah, it's QT interval. Bit of a nightmare sometimes, but
Yeah.
I think there's new machines on the way apparently that we're gonna hopefully get better EKGs and less noise. So real quick, basically we have a 56-year-old who has hypertension, just admitted after an MBA. We were consulted, hey, this patient's having atrial fibrillation on tele, he's symptomatic. We come and we see him, we say, okay, well, let's do stress echocardiogram on him. We show that there's no evidence of ischemia, normal LV function, his labs are all normal, and we say, okay, well, what's his CHADS VAS score? Well, he just has a 1 because he has history of hypertension. In this case, an aspirin would be appropriate for him. We wouldn't need to put him on a blood thinner. Treatment, in this case, we know there's no structural heart disease. We can send him home on flecainide, see how he does. Follow up as an outpatient. Next would be a patient older, significantly more comorbidities, so an ischemic cardiomyopathy, diabetes, hypertension, who is found to have paroxysmal atrial fibrillation, difficult to control, RVR during the hospitalization. So we'd evaluate this patient and we see, okay, well, their LV function's about 50%, her creatinine clearance is okay, but her CHADS VAS score is a 5. And so we'd say, well, we need to keep this patient, hopefully they're already on their blood thinner. So we continue the apixaban. We'd consider doing a cardioversion, let's get her into normal rhythm. In this case, we'd select sotalol for kind of long-term management. So in this patient, her LV function's kind of borderline. I don't think Multac's a good option for her. I don't think she's going to tolerate it, and it's not a great option again for long-term therapy. So in this case, we keep the patient here, while her pneumonia resolves as we're loading the sotalol. Next patient would be, gentleman, ischemic cardiomyopathy, atrial fibrillation. He's had 2 ablations. He's not tolerating Multac. And so we say with this patient, well, our options for therapy are pretty limited. With the, as we kind of look through our options, we say, okay, well, his LV function is kind of borderline, labs are in range, CHADS VAS is the 3, we need to make sure he's on a blood thinner, and his baseline QT is appropriate. So in this case, we'd say, well, let's continue Eliquis, but again, because I think I meant to say, yeah, this would be a patient with COPD or asthma. We'd say, well, we can't put him on sotalol because it's going to worsen his asthma. Let's do dofetilide. So this would be kind of an appropriate patient for that, because again, we've ruled out other medications. He's already had 2 ablations. We need to go for upping our medical therapy. This is something that we see, somewhat frequently, especially with our some of these sicker patients. Well, we see them because every patient with this ends up seeing us. But you have a patient who has ischemic cardiomyopathy. They have an old infarction. They're having recurrent ventricular tachycardia that their device is detecting and terminating, either by rapid pacing or shocking. So this patient clearly is not having a very good quality of life because they're continuing to be shocked. At one point, they're started on sotalol, which again can be effective, but they're still having refractory episodes. And we'd say, well, let's make sure that this is appropriate therapy, and we need to make sure that there's nothing new that's causing this. So anytime we see a patient who's having ventricular tachycardia, we ask our interventional cardiology colleagues to say, well, let's make sure he doesn't have a new infarction. We know he has coronary disease. Let's make sure there's not a new area that's ischemic, and that's why we're getting this ventricular tachycardia. So in this case, ischemic evaluation, a lot of old stable disease, nothing new. And so then we'd say, okay, well, let's put this patient on amiodarone. We need to prevent these arrhythmias from occurring as a temporizing measure while we can consider doing a VT ablation for this. And so going in there and trying to electrically terminate where this ventricular tachycardia is originating from. So again, one of the kind of rare circumstances we'd say, well, this is a patient who needs amiodarone. And likely, just continue to monitor as an outpatient. Many other, scenarios, and that's kind of what my life goes into, is thinking about what medication a patient needs to be on. But anytime there's questions, why is this patient on this medication? Just get asking. I'm always happy to help out with that, answer any questions. Any questions about the world of EP?
No, thank you so much.
Yeah,
That was excellent.